Welcome to the ICD-10 workshop.
I wanted to introduce myself to those of you who are brand new to joining us today. I am Kelly Whittle. I'm the owner of Whittle Advisors, and I do ICD-10 transition planning, not only for hospital systems, but for clinics and physician practices. Welcome to the workshop number 3. This is the third of the four in the series. That's harder to say than it seems. And today we have a full agenda for you. We had some designated topics that we have been promoting for several months now, and in addition to that, I've added some what I hope are treats to share with you. If you've been to previous workshops, you might have picked up on it. I am a data geek. I love information, and so when I come across things that I think you would find valuable, I set them aside, and then we build the materials. We attempt to incorporate them into your learnings. And so I hope today is very exciting for you. I hope that when you leave here, you'll feel that ICD-10 is doable. It's a big transition for our industry. It is a serious transition for our industry, but I do want you to feel empowered, like you have the tools to make the transition and to be successful in a post-ICD-10 compliant world. We have 3 documents for you today. One are the slides, and certainly that's pretty familiar to you. You've seen these slide packets in each of the previous workshops. In addition to that, there is a medical necessity workflow document, and that's the one with the color boxes. And then finally, there's a third. It's a 2-sided document that includes ICD-10 data elements, and we'll talk about how you can use this in your preparation as we make the transition to I-10. Today on our agenda, we are going to use our polling process. So once again, you see the green glass beads and the blue glass beads. Remember, the green is representative of yes or a positive affirmation, and the blue is no. We're going to talk about education. If you recall, way back in October, we talked about the importance of an education strategy being the foundation to this transition. We shared with you some potential items that you might want to subscribe to through Precise University. These were educational materials that were geared at helping each individual role meet the needs of ICD-10. But there are many other products and services in the market, and you should certainly find the product or service that best meets your needs. Today I'm coming back to show you the outcome of an education pilot, and I think you're going to find the results to be really interesting. The net new here is this piece on documentation. I'm not a coder, and I shared that on the very first workshop. I'm a program manager, so I design and implement large-scale change. I've done this for more than 20 years on an international level. If you know a company called Thomson Reuters, you're familiar with a corporation and an environment in which I worked for more than a decade managing large-scale change. I've come to Traverse City now. I think this is month number 5. And yes, most of it, there was snow on the ground. Surprise. But my family is doing well in the transition. We finally gotten my junior high son, he's in 8th grade, to wear jeans. This is a miracle. If you've dealt with a 14-year-old boy, you know how fond they are of short pants. And so it took a while, but he has bought a pair of jeans. We're going to talk about this documentation. This is a brand new concept, as I mentioned. And then also we're going to come back to process remediation. I do want to introduce a colleague of mine in the room. Gabe, would you stand, please? This is Gabe Genoviak. Gabe works at Munson Healthcare. He's an expert in process management and change, and he has built our diagram today that we're going to use. Gabe's only able to stay with us a short time, so let's thank Gabe for his contribution. As we wrap up today, we'll take a look at our community polling results. This is a process that we've been using through our workshops. We'll be able to see exactly what we're doing and what we're thinking as a community. And finally, our step-by-step strategies. These are those action items that you need to be thinking about as you take the material back to your practices and begin the implementation. This information I actually pulled from a fact myth document coming out of CMS. And so they've written their fact this way. They say, as with ICD-9 CM, ICD-10 CM PCS codes should be based on your medical record documentation. While documentation supporting accurate and specific codes result in higher quality data, non-specific codes are still available for use when documentation doesn't support a higher level of specificity. So this is a huge gold nugget. For some of us, we were concerned that these non-specific codes were disappearing. You might have heard on other calls or read in other places that non-specific codes will not be paid. That was a concern for the industry. If you go back and take a look at the documentation and the code set, you'll see that there are a number of non-specific codes still available for your use. And one place that you would find this really valuable and appropriate to use is before a diagnosis has been confirmed. We all know that many diagnostic tests and orders need to be placed before you get confirmation of what a provider is thinking might be the root cause or the problem with their patient. Well, you can't know that somebody has diabetes until you've proven that they have diabetes. And so a non-specific code might be appropriate there. Another place that you could apply this is if you're determining whether a patient has a specific type of virus or a bacterial infection. You often don't know the causing agent until you test for it. Therefore, in the meantime, you would have a non-specific code on the documentation. Does this make sense? Good. I hope you now can breathe a sigh of relief because all of your non-specifics aren't going away. We do want to be as specific as possible. We want to tell as complete a story as possible with our documentation, but there are times when we'll need to use non-specific codes. Okay, I do want to set the stage for our education pilot. This education pilot was conducted in the northwestern part of the United States. It was conducted amongst providers in the practice setting of multiple types of specialties. So this was not a primary care pilot or a surgeon's pilot. This was a multi-specialty pilot. It included 16 coders, and when I say coders, I mean folks that are truly doing coding, so coding type functions, and it included an equal number of physicians. The physicians were educated in the new documentation code set, the types of information they need to put into the medical records, and then the coders were also educated in the new coding guidelines, how to apply the codes, how to pick a code, how to look at the documentation and ferret out where they might add supporting codes to the claims. And this is what they found. When they surveyed the coders, now this is post-education, they found that prior to dual coding, that's the blue bars, dual coding is the native practice of use of ICD-10, so before they started practicing, but after they received the education, they had pretty high confidence about their ability to use the ICD-10 codes. And you can see the various questions along the bottom that were part of the survey. But what we found was that after they participated in dual coding, meaning the doctors added the additional detail that's required for I-10, and they started to natively code in ICD-10, their confidence level increased. Now, that is a no-brainer. Your mother spent your entire childhood telling you that practice makes perfect. If they get to use it, they feel much more confident in their outcomes. What you see from a statistical perspective is that this confidence level increased a lot. If you have done statistical research, you'll know that a small tenth of 1 point is a big bump. These are whole points that we're seeing as a difference here. So my recommendation to you, and we didn't really talk about it very much in our education strategy sessions, is that you get through your education, both your provider and your coding staff or your support staff. Finish whatever education strategy you've developed prior to go live, prior to October 1, and then spend some amount of time dual coding. Maybe it's one encounter a day, maybe it's 10 encounters a week. However you can fit it into your workflow without causing disruption, start to use those codes. There's nothing that prevents your providers from adding the additional detail into their SOAP notes or their encounter documentation now before they go to I-10. All of that data is valuable and will strengthen your medical records against audit. Let's go to the next slide. Now this is where the aha, of course, we understand, gets a little bit interesting. Our providers did the education, and again, you'll see that pre-dual coding, our providers were pretty confident. As a group, that won't surprise you. Doctors tend to be really go-getters. They're going to accomplish a lot. They've come a long way to earn that profession. So we're up at 4.8 with their ability to use I-10 codes on the job. That's before they dual coded. Then what we see, interestingly, is when we surveyed them after the dual coding, their confidence dropped. So intellectually, they understood the new detail. It's part of the clinical process that they go through when they're thinking and interacting with their patients. But when it came to adding the detail into the medical record, it got a lot harder than they expected. We see significant levels of drop here. We see that here, when we ask them, can you be as productive and accurate in I-10 as you were in I-9? More than 1 percentage point drop. Went from a 4.3 to a 3.7. That is very significant. Remember, when you do a pilot and you're looking to engage others to do something extra on top of their day job, you typically get those that are highly engaged. They want to be successful in ICD-10. They wanted to do the education, which isn't a small amount. It was hours and hours of education. So these typically tend to be your cream of the crop. And they struggled when it came to putting the data down. Let's go to the next slide. What we also saw, and you might find this to be of interest, is that we had some of our participants get all the way through the education. We had others that did not. All of our coders finished the education. Some of our doctors did not. We found that the participants who did not complete the training had a higher confidence rate than those who actually completed the training. They didn't know what they didn't know. It's really important that your physicians do the health stream education as it's designed and or any other supplemental education that they feel they might need. Encourage them to get in there and learn what it is that they're being asked to do. Okay? This is another key nugget for you. If you have coders in your practices, what we found here is that in I-9, in the practice setting, it took about 1.65 minutes to code an I-9 encounter. It took 3.66 minutes to do that in I-10. You see more than a 200% increase. That is very significant. If you have a coder that codes 40 hours a week, suddenly you need 2 more of her. Here's a high-level summary of the data analytics. There is a very strong correlation between time to complete coding in I-9 and time to complete coding in I-10, meaning the coders that were fast in I-9 were fast in I-10. This correlates exactly in the same manner along quality. Coders that are highly productive and have very good quality in I-9 are highly productive and have very good quality in I-10. If you have a coder that struggles in I-9, wow, it's going to be difficult to make the transition to I-10. Those are the coders you'll want to give some encouragement to, give an opportunity to take some additional learnings. Folks are really encouraging the study of anatomy and physiology so that they understand the body systems when they go to the books or the tools to try to determine what codes apply. In addition to that, we found that the quickest time to query the quickest way to resolve any questions due to coding is face-to-face. So if you are using an email, a paper tracking system, a way that you document queries and hand to a provider, That takes much more time than setting up 5 or 10 minutes per day or 5 or 10 minutes every other day to face ask them about a question you might have with an encounter. If you don't have that as a regular practice today, I recommend that you institute it, even if you institute it just for the transition period. That leads us perfectly into our conversation around documentation. There are specific areas of impact to physician practice documentation, and it includes all of these items listed on our slide today. Today we're going to focus on medical necessity and our EMM codes. I brought examples of both, but I don't want to downplay the fact that CPT codes and diagnosis codes are an area of impact. CPT codes will not change in 2014. You can expect to see adjustments to the CPT code taxonomy in 2015 and 2016. Something to keep in mind. Non-specific and unspecified codes, we've talked about this already. They are permissible. Severity of illness, and then orders of diagnostic rule-outs. Our focus today, medical necessity and EMM codes. On your handout, you'll see, this is the one titled Required ICD-10 Elements for Orders and EMR Templates, Primary Care Physicians. Do we have any primary care folks? Excellent. Okay. This document is ideal for you. It's designed from our HIM experts or coding experts with the primary care type of documentation and code use in mind. I want to encourage the rest of you not to toss it in thinking it's not valuable. Many of the concepts apply to all specialties. For example, acuity, type, laterality. Certainly others other than primary care will deal with pregnant women. You might deal with a patient that has had an AMI. Diabetes is at an all-time high. Asthma. Some of these diagnoses and additional documentation requirements will apply to other specialties. We are building, Munson, when I say we, Munson is building out these data element sheets for various specialties. It will take us time to get through the majority of specialties. For example, we have this one for primary care. We're certainly focused on surgery. We're also focusing on neurology. We're focusing on cardiology. We're focusing on orthopedics. As these sheets become available, they'll be posted and shared both through our Munson's physician liaison team and on the Munson internet site. If you haven't gone to the Munson internet site and seen the documentation tips, it's similar type of information laid out a little differently. It compares how we code in I-9 today and what the additional detail is required in I-10. If you haven't seen those, I encourage you to pop over to the Munson intranet site and take a look at them. If you search that site for ICD-10, you'll come up with a page that includes the documentation tips. I'm confirming with Deb. She said, yes, I got it. So let's get back to talking about diagnosis documentation concepts. I've pulled just 2 concepts out of the handout, and I've brought them here so that we can talk about them together. One is asthma, and the second is diabetes. And so you begin to pick up the detail of ICD-10 in these types of diagnoses. For asthma, we'll need to start focusing in on not an unspecified asthma, but whether it's mild, moderate, or severe. Second, you'll want to pick up whether it's uncomplicated, intermittent, persistent, exercise-induced, and if the cough is variant. Now that is a large amount of detail to consider when you're documenting one disease state. Some of our patients might have 4 or 5 chronic disease states, and so now you see the amount of detail and variance becomes more complicated. That's why we want your providers to get through the education, because the education will start to expose them to this level of detail and specificity. For diabetes, you'd want to emphasize whether it's type 1 or type 2. You also want to pick up whether it's diabetes mellitus due to underlying conditions. Don't forget to document which body systems are affected, whether it's a complication or a manifestation, whether it's drug or chemically induced, and then certainly document the use of insulin. Now, when you think about these details today, are you already capturing this level of detail? Some of you will already be capturing this level of detail. Some physicians are so thorough and they are, very adept at their paper-based documentation or their EHR, EMR, and so they pick up this type of information just as a routine part of their role. Others are not picking it up, and therefore they need to become aware that this level of detail is becoming the norm. Okay, I brought you a medical necessity case example, and you'll see here that this is a 66-year-old patient with colitis. It's being seen for the evaluation of excessive fatigue and bleeding. The diagnosis in the chart is just plain old anemia. On the next slide, you have a comparison. You have an I9 anemia unspecified code, and then your procedure is down here at the bottom. And this is felt to result in a denial. Anemia does not support the colonoscopy procedure, therefore you're likely to get it denied. And this is not an inexpensive procedure. Just saying. It's $2,500 or $3,000 or more. Here, with the appropriate level of detail, we pick up that it's ulcerative with bleeding. We also pick up the iron deficiency anemia. And then down here is the procedure, and it's felt that using what we know today, information coming out of the paying system, so Blue Cross Blue Shield has already put out a crosswalk from 9s to 10s. They've been speaking on ICD-10 preparation for 5 years. They are way ahead of most folks in this. We feel that this claim would be accepted. I do want to mention to you, for those of you who have a large population of Medicare patients, you'll be very familiar with the NCDs and the LCDs that are published by CMS. CMS will publish the I-10 version in April of 2014. These LCDs and NCDs, of course, you can access them on the CMS website for the most up-to-date latest version, but you can also access them on the Munson website if you wanted a quick, easy-to-scan version of these LCDs and NCDs. It's important for us to stay current on the LCDs and NCDs in order to prevent hospital service delays. And I do want to mention that the hospital order forms are being revised. When they are finished, we will share them with you. It's likely to result in a packet. There are many of these forms that need to be updated. Before we go to EMM codes, I do want to ask how many of you are working in an electronic system that requires remediation to some paper-based template, some order form? Are you working in a NextGen or Allscripts where you transition orders right out of your EMR over to the hospital? If you are working in that type of system, it takes time if your vendor is going to update those electronic order forms. You'd want to get started working with them right away. It is likely that your vendor, I say the word likely, it's likely that your vendor will know the additional detail that you need for those forms. If they do not, this is a great place to start, this data elements sheet. Make sense? So you'd want to, if you're orthopedic service and you deal with a lot of injuries, you'd want to pick up concepts like laterality. Is it a bilateral injury? Is it left or right? Okay, let's take a look at the EMM codes. We have a case study here. It's a 56-year-old male. He presents as a new patient complaining of severe heartburn with generalized abdominal pain. He also reports recurrent vomiting with observed blood. I'm going to try to be cautious and not to read the whole thing with breakfast here. What we see is that he was a chronic smoker. He has a chronic smoker's cough, which is a result of his cigarette dependence. This is a huge concept in I-10. Our government wants to know who's using tobacco products and what type of tobacco products and for how long. And they even want to know if it's secondhand smoke. This is big. This is likely to be some type of registry if it's not already being captured. We've done a comprehensive history and provided a comprehensive examination. We've also consulted with the pulmonologist for a coordinated plan of care. So the diagnosis in the chart is generalized abdominal pain and hematemesis. Thank you. What we have here are our EMM codes and how they break down. For ICD-10 on this side, we have captured the generalized abdominal pain and hematemesis. And then finally, the CPT code at the bottom is an office visit for the EMM code for a new patient requiring a detailed history, detailed exam, and medical decision making of low complexity. You see this is a 99203. On your slides and handouts, the boxes were exposed. The one on the left-hand side was referred to as an audit risk. The one on the right-hand side was referred to as not being an audit risk. I've had several opinions in the last few days regarding this slide. The clinicians that I've consulted with feel that the audit and no audit risk labels were not exactly accurate, so they have encouraged me to cover the boxes with less specific and more specific documentation. That's really the concept of the slide, is to compare the documentation levels required in ICD-10. So here, the workup that was completed from our case study, we know that we have identified that the patient has heartburn, he has generalized abdominal pain, anemia secondary to blood loss, bronchitis, long-term use of NSAIDs, and nicotine dependence, which are cigarettes with other nicotine-induced disorders. You see how specific our nicotine code is? There's a whole slew of these codes in I-10. And here, you'll see that we're able to bump the level of our code to a 99205. That's a much higher E&M level and should result in a higher reimbursement just by adding the detail that by coding the detail that we've already gathered. Does this make sense? Okay. So let's continue our physician documentation discussion. This is the AAPC white paper that I shared at our very first workshop. We touched a little bit on documentation at that time. I've brought it back for a second look. What you see in our case study here is a story about Mrs. Finley. She's had an accident in her kitchen, a cabinet fell on her. All of this might sound familiar to you. We know that her husband, who was home with her at the time, told her she was out cold for about 2 minutes. And then she has had subsequent headaches. They come on suddenly. They last for long periods of time. They occur every day, and they are not relieved by over-the-counter pain medication. Here, on the right-hand side, we start to pick up the concepts of documentation specificity from ICD-10. So you see the salmon color is the external cause detail. ICD-10 wants to know how the injury happened, they want to know where the injury happened, and they want to know if this is a first injury or a subsequent injury. So you might think a cabinet falling on a woman in a kitchen. I hope it's the only time she's experienced that in her entire life. But for a child who has had 3 broken arms due to falls or skateboarding or whatever is the cause of that, you'd want to track that over time. There's obviously some potential long-term impacts to a child who has a recurring broken bone, and maybe there are underlying reasons for that. Maybe there's a calcium deficiency or some other deficiency that might lead to the child's bones being fragile. Here, under the green, we pick up activity. We see in ICD-10-CM, the activity of the patient needs to be documented. So here she was in her kitchen cooking. So we picked up that detail. We know that the ICD-10 codes are getting longer. There are more characters in the code set. So this 7th character is an extender that identifies the encounter. And that's that initial encounter, subsequent encounter, sequela, detail. You'll see this in the code set. Lots of these codes get extended by a 7th character. Location. Documentation needs to include the location of the patient at the time of the injury or other condition. We've certainly picked that up. It was her kitchen. We want to pick up any specificity. She has a concussion. What type of concussion? What other details do we know about the concussion? This orange colored band tells us we're digging into relief or no relief. There's not much that we need to do likely if she is getting relief from her problems, if her problems aren't as manifest as they were upon original injury. And then the very bottom blue band is acute versus chronic. Now on our very next slide, yep.
It's probably a stupid question, but when they come in for follow-up, we don't have to repeat all those codes again. For subsequent.
God bless you. Do we have to repeat them? I don't think you have to repeat them from a historical standpoint. What you need to document is what they're still presenting with. So some of the codes would carry forward if she's still manifesting problems from this injury. The second slide on this topic, you see again, I've left the color codes here. You start to pick up the various codes used from ICD-10 CM. That's the far left-hand side. And then all of these additional details by color code. So we pick up the place, we pick up the initial encounter, we pick up the concussion, we pick up the fact that it was acute. And this is the piece that should guide your strategy, this gray kicker box. We anticipate that 50% more physician queries will be presented by our coders. So if you have a coder in your practice doing coding, and I'm sorry that I keep saying that, but people use coders in different ways. Some use them only to audit because of the EHR. Many providers are choosing their own codes through the EHR, and coders then are used to augment or audit the records only. They're not taking clinical diagnostic information and clinical encounter information and finding the codes. You see the subtle difference? So if your coder is taking that written documentation or those clinical concepts and applying it to codes, we expect that they're going to have 50% more questions about the detail than they have in I-9. That's a big hit to productivity and something you can plan for and something you can mitigate through dual coding, that practice. And then secondly, we expect a 3 to 5% decrease in physician productivity per note. This is a really low expected hit on our providers. I have seen as high as 10 to 12% productivity hit, but AAPC is saying 3 to 5% productivity hit. This is pretty similar to going from a paper-based environment to going into an electronic environment. Until you get very familiar with the electronic environment, it takes providers longer to make their documentation. It's no different with this code set, and it is something that over time we should be able to work ourselves pretty close back to normal in the physician practice space. Anybody in a paper-based environment today? And do you have coders in your office? Yeah. Mm-hmm. And so if you don't mind, I'll ask another question. Do you have a strategy that says we're going to update our code set, our reference code set that the doctors are choosing from, or how will the doctors make those choices?
Well, we are switching to MRI relatively quickly.
Mm-hmm.
As part of it, and then I was saying earlier that we're ophthalmology specialty,
Mm-hmm.
and so we are already going through chapters of eye segments right now, and they're ready to start. It is such a huge change.
Yeah.
There's no way you can have a issue to have all the diagnoses on there, so we're going to utilize that cross-functional EMR to help guide these physicians.
Do you mind telling us which EMR you're using?
We're going to MD Intellisys.
Okay. Great. Yeah, that's a really solid plan. I love the fact that you're already looking at that code set to say what is the additional detail that's required, and let's become really knowledgeable and familiar with that. That's great. It's also a good strategy to not try to build out that fee sheet, because you're right, you might end up with 9 pages or 10 pages of possible codes. Good work. Okay, let's go forward. I do want to share with you that the work group for electronic data interchange, it's often referred to as WEDI. This is a think tank out of Washington, D.C. They work very closely with CMS. This is often the group that takes the regulation and determines how in the world, as an industry, we could actually implement it. For example, many of you will be familiar with the 4010 to 5010 transition. This group was very instrumental in proving that that transition would get us to where we needed to be so that we could implement ICD-10. It's a very well-known international group regarding not only HIPAA safety for documentation, but also what is the layout of data? How do we move it from place to place? They expect that ICD-10 is expected to be the most costly government-mandated change ever to hit the healthcare industry. You'll recognize Stanley Natchinson. I bring Stanley's quotes to you. I've shared with you his budget analysis. Stanley works closely with WEDI. He's the one that said if you're working for a 3-provider practice, you can expect to spend almost $100,000 for your practice to move to the use of I-10 codes. If you have a 9 or 10 provider practice, you're looking a lot more. I'm sorry, I think it's like $500,000. It's in the first set of workshop slides. Let's talk about process remediation. Last time we talked about what the circles, squares, diamonds, arrows meant. I encouraged you to take a look at specific processes within your organization. Deb will go forward. Here are our squares, our diamonds, and our circles. The circle I've added, I think I mentioned it last time. For some reason, I didn't add that to our slide, so I've augmented a little bit. What you find on the handout is that the circles are your starting and end points. Just a way to designate that you've landed where you need to be and that there's no further movement. So it's your beginning and end points. We talked about these at-risk processes, your patient registration process, your orders process, and again, Munson will share updated orders, materials, forms, documents, specs with you. If you deal with other facilities, you'd want to look to them to give you updated order forms, specs, information as well. Definitely coding will be impacted in billing. Medical necessity is the handout I have in my hand, and then disputed claims. So the last time we were together, I asked the participants, what type of sample process flow do you want to see? And you told me medical necessity. So let's take a look at the handout. On the handout, we start, this is an I-9-based medical necessity check. And so at the very top, the green oval, we have determined the patient's diagnosis. So gather that diagnosis information. And then we move down to record the diagnosis code in the appropriate space on the requisition form for an ICD-9. Now, obviously an ICD-10 would apply here as well. So you can think of this as a standard current state, and you could certainly augment this handout to apply to your I-10 environment. We move from that order form, order template, right down to reviewing the local coverage determinations and the national coverage determination lists. And so as I mentioned, some of you will be doing this through your electronic system. There might be an automatic check that goes out and bumps against these reference tables called LCDs and NCDs, or you might be going to a website. You might be searching for your diagnosis code to determine which tests are deemed medically necessary by Medicare. Anybody going to a website to prove LCDs and NCDs? Good. If you're not doing that today and you have trouble with this process because these things keep coming back to you deemed unnecessary, you might want to include this process in your workflow. After you've checked to determine if your diagnosis code is supporting the test you're ordering, if you get a yes, that it is necessary, then you've met the medical necessity and you can go ahead and order that test or diagnostic. If you find that the test isn't listed under the diagnosis code as being medically necessary, doesn't support it, then you get a no, and that drops you straight down to the next dialog box, the next diamond, which says, is there time to retrieve a new I-9 code from the provider? If the answer is no, then we recommend you obtain an ABN. So this would be happening at the lab, at the radiology center, somebody coming in to get an x-ray. They're going to ask your patient for an ABN. If we find that there is time to get a new code from our physician, then we move to the left and we see that we're asking the physician for the new code. If we receive that, then we bounce up to where we're checking to determine if the new code is medically necessary, proves the medical necessity of that procedure. It's a pretty simple process flow. When you see it diagrammed, does it give you insight on how you might go about reviewing the other processes like patient registration, orders, coding, billing? You see the symbols that are used? Whenever you start, use the oval. When there's a question, you use the diamond. When there's a decision, you use the square. This can be done in Visio, which is a great tool. I don't recommend it if you don't have it. It's a little bit complicated to use, but you could also do this in PowerPoint. You could do this in Word or any WYSIWYG type word processing editor. All right, our step-by-step strategies. At the end of each of our workshops, I attempt to give you the immediate next steps, something that you can think about as you leave. And so certainly, education. You want to get the education completed for all of your impacted roles. Has anybody here completed the education process? Has anybody chosen a vendor or source of information for the education? Good. If you haven't chosen that source of information for the education, I really encourage you to have those conversations and make those decisions sooner than later. You want to complete your technology upgrades. So in the first workshop and in the second workshop, we talked a lot about technology. We talked about how to talk to your vendors, talked about what type of functionality you would be looking for. Anybody struggling with the technology upgrade? Any questions on timing, capabilities? Everybody has a plan? Yep.
So if we know that our EMR is going to use the gems for the codes, can we actually use
Are you sure your EMR is using GEMS to translate the codes? What is your EMR? Are you referring to IMO?
Yeah.
IMO doesn't use GEMS, thankfully. What IMO uses is a full taxonomy. IMO is a taxonomy company, and being a data geek is so exciting, but most people it's not very exciting, but for me it is. And so I'll tell you a little bit about IMO. IMO is a great keeper of taxonomies. A taxonomy is a subject matter list of concepts. And so here in our space, they're clinical concepts, they're medical concepts. And so they're experts in ICD-9, they're experts in ICD-10, and they're experts in a natural language that's used internationally for healthcare called SnoMed. And what they've done is they've taken all these really smart subject matter experts and they've put them in a space and they've said, if we go from I9, how do we get to I10? And that's the one-to-many. You know, that's one code in I9 for, I think there are 5, Jenna Culver would know this, but I'll try to channel her. I think there are 5 codes for a fractured finger in I9. There are 1,800 codes for a fractured finger in I10. So that's the breadth of one-to-many, 1,800. For these very smart people who got into a room and they work for IMO, they decided, how do you get from I9 to I10? Well, they said, we can't get there easily in the 1 to 1,800 range. So they put this middle ground in, this clinical concept, SnoMed taxonomy, and they said, but we can get very cleanly from I9 to SnoMed, and we can get very cleanly from SnoMed to I10. Because SnoMed has a relationship. They have parent concepts like asthma, and then they have child relationships under asthma that includes all those various details, the chronic asthma and the acute asthma and all the other variations. And it's those variations, the minute detail under asthma, that map very nicely to ICD-10, almost a one-to-one. It's really beautiful if you're a taxonomy person. But it also allows them to climb the chart back to asthma to get to the I9 side. So you build all of these fingers and web type connections between the 3 languages. And so that's what IMO does for you. It allows you to type in the clinical concept and then expose either the I9s that you're using today or the I10s that you'll use in the future. The really exciting piece is that IMO is agnostic of your EHR. Many EHRs can have this IMO tool sit right on top of the EHR that your provider pops into, does a little Google type search on a clinical concept, and then it will walk that provider through a tree of options until they narrow down the 1,800 codes to 1 or 2 that they choose from, and then that typically gets popped back into your EHR. It's really cool stuff. So Dr. Quinn, I think you're good with the IMO, and it's not, you won't see the errors of GEMS. Good.
And that was really good to understand that really
Good, good. SnoMed is actually the international language of medicine. The World Health Organization made that decision. So internationally, across hundreds and hundreds of countries, we're all targeting toward this taxonomy called SnoMed. And as of 2015, you'll start to see the SnoMed language in not only your vendor-supplied tools, but in reports, in federal reports, and government reports, and international statistics. It's pretty interesting stuff. Okay, so that's our technology. The next piece I want to talk to you about is dual coding. And Deb, what time is it?
Oh, it's 22.
11?
22.
Okay, if you'll give me 5 or 6 more minutes, I want to hit the highlights of dual coding. I didn't build out a slide for this, but I do think it's really important that we start to think about dual coding and what the key concepts are as part of this strategy. As I mentioned, education is the foundation to our work. And so while we're gathering the knowledge of what ICD-10 requires, I want you to think about when all of your preparation is going to meet. So we have our education, we have our technology, we have our forms remediation. At that meeting point on the calendar is when you should think about dual coding. So if you need a technology upgrade and it's not coming till May, you can't possibly dual code until after you have that technology in May. Once you set up the date to begin your dual coding, I want you to identify some super users in your practice. So this would be a provider or 2 providers that are highly engaged. They like documentation, they understand the value of ICD-10. Then I want you to get your best registration person, coder, and biller. Work with a really small pilot set of folks. You need one representative from each of the impacted roles. Then I want you to set up some guidelines and rules. So we obviously can't pay them to come to work and practice I-10 coding the entire day. But what we want to do is we want to get enough practice to know where our strengths are and where our weaknesses are. So if, for example, you see 10 patients in a day, and you can code 2 cases a day in I-10, that's a great strategy. If you can only code 1 case in I-10, it's worth doing. Any amount of practice is worth doing. The thing to think about before you get your team assembled, before you give them the objective and the guideline, is what in my process needs to change in order to allow us to capture the additional detail. For example, where in the EMR are they going to put this detail? From a provider perspective, it's likely that nothing will need to change. They just need to add the detail. From a coding perspective, it will need to look different. They'll need to continue to produce I-9 codes for billing, and they'll need to determine what the I-10 codes are. You want to think about this carefully so that you don't inadvertently try to drop the I-10s before October 1, because it will get rejected. So just work within your EMR to determine where the additional codes and detail can be applied and recorded without causing a billing issue. Once you have some data gathered, so if you're doing 2 records a day, I would recommend you take about 2 weeks and you gather all of the detail, all of the data that you've already coded. And I want you to think about a few things. Number 1, how long did it take us to add the detail? You want to capture that. So that might be a little tally pad in the encounter room where your doctor says, I was putting an I-10 level of detail and it took me an extra 4 minutes, or it took me about 5 minutes, or it wasn't any big deal. It's great for 2 reasons. Number 1, we'll get the provider's response, but number 2, we'll be able to correlate the time spent with the quality. If the doctor put in additional detail, but it wasn't really good quality, they haven't captured the essence of I-10 yet, and they only spent 2.5 minutes, then we need to give the feedback that says, we need you to slow down, we need you to spend a little more time, or here are the documentation concepts that you missed. Then from a coding and billing perspective, you'll also want to capture the quality and the time. So think about how to capture how much longer it took our coders to code in I-10 and what the quality of that is. When you get the time and the quality to align, you know that that is your impact. So we have very good quality, and we know that it's consistently 5 more minutes or 10 more minutes to do the work. Then we know that for a period of transition, we're going to lose that much productivity, and we could do a few things with that. We could hire a part-time person. We could take longer to do our coding and billing. All of those are business decisions that you can adjust to once you have the quality and the time determined. What questions do you have for me?
Is this really going to happen?
Yeah, it's really going to happen. These workshops are being presented here to this team. The information that the doctors are getting it's a multi-phased plan. And so the first phase rolled out in the fall, and it was awareness training. There are up to 4 modules through HealthStream sent to each physician. The second phase of that is section-specific meetings. And so we went to the ambulatory section last week where we presented impact data. Providers love data, and so we've gone with very specific detail on what is the level of unspecified codes being used, where do we see the clinical concepts changing by specialty. So it's information like the handout that says we need laterality, we need acuity, we need chronic versus acute. By specialty, we identify those documentation concepts that are most important for them to understand. We've shown them some examples. So the information you saw today on E&M and medical necessity, we presented last week to the ambulatory section meeting. Each section will be presented with their own packet of I-10 information and allowed time for dialogue. Then the third piece of the physician readiness program is to bring them back to HealthStream for specialty-specific courses. Now these specialty-specific courses through HealthStream, which will be rolled out in the spring of this year, tend to be very short. 20 minutes, 30 minutes, but it's highly targeted to these documentation concepts that impact them. So again, for orthopedics, you'll see things like the fracture scale. You'll see things like laterality, picking up left versus right, opened and closed fractures. There's many additional details associated with capturing detail around fractures, whether it's an initial fracture, subsequent fracture. I do want to second the endorsement for Dr. Donnelly's Grand Rounds presentation. Dr. Donnelly is an expert in documentation. She's taken a view of this regulatory transition in a pretty broad scope for this presentation. And so what you'll find is not a repeat of the I-10 concepts, but more of a broad view that says, due to healthcare reform, this is how documentation is changing. This is what the future looks like from a clinical documentation perspective. And she touches on a number of different regulatory initiatives that is bringing about this change. And certainly meaningful use is not a small piece of that, it's a very big piece of that. And that's what we're honing in with the iPath transition. It's what your EHRs, EMRs are doing when they're upgrading. They're giving you the greater capability to document at a more detailed level. So I do encourage you to either join by WebEx, join in person, or to get the on-demand version or the recording. Okay, thank you very much for your participation today.